I'm going to make this one quick. Well, we have Dr. Sarat Thikkurissy. He is the chief of dentistry at Cincinnati Children's Hospital. He's going to tell you a little bit more about his background as part of his talk. So I'm going to go ahead and pass the mic over Dr. Thikkurissy.
Thank you all for inviting me and for being here. This is one of those talks where it's always a little intimidating and awe-inspiring because I've probably learned as much from my patients and parents of patients as I have from my faculty members. And a lot of it is simply what type of priorities and how to explain some of the manifestations of these diseases in a way that is meaningful. So as a dentist, I've been a dentist for 26 years, a pediatric dentist for 21. I'm originally from Southern California, lived my whole life there, did undergraduate there, did everything there. So when it came time to apply to dental school, my only criteria was I needed to get out of California. So I went to NYU, I went to New York, got to live in New York for 4 years, unbelievable experience. Towards the end of my dental school, I applied for a military scholarship. They paid for the last couple of years of dental school, and I was in the Air Force for 8 years. That included some time up here in Dayton, Ohio at Wright-Patterson. Then I was stationed in Cheyenne, Wyoming, which was a culture shock. And I can say this, I was the only Indian in the town of cowboys. Definitely, first time wearing cowboy boots, I could not pull them off. Then after that, I did my pediatric training at Ohio State University, Nationwide Children's, which was then Columbus Children's Hospital. And after that, went to Germany for 3 years to pay back my military time. I was the only pediatric dentist and was responsible for about 15,000 dependents of active duty. So that's really where I cut a lot of my clinical chops. And then came back as a faculty member at Ohio State for 6 years, then came down to Cincinnati, where I've been just over 11 years as the chief of dentistry. And I'm very fortunate in that Cincinnati Children's, and Dr. Saul is a great example of that. A lot of the physicians have a very high dental IQ and understand the impact of oral health and dental health, not only on the patients and their families, but on the other conditions that are being treated. So having said that, what I'd like to do is talk a little bit about HPP and oral health. Very often, so I've probably seen about, I'd say 15 to 20 patients over my career with HPP. Most of the time, as has been explained, the chief complaint is early loss of a baby tooth. What's interesting is, and in this image on the upper left, is that it's not only early loss of the baby tooth, but the baby tooth comes out completely clean. There's no blood attached to it, nothing attached to it. It's just a very clean tooth, which piques a lot of parents' suspicions to begin with. We may see radiographs such as the one here on the upper right, showing early loss, and then we may get children that we see who clinically present with early loss. All of that triggers our questions. There are differential diagnoses or other conditions that can manifest with early tooth loss. Some of the more notable ones are Papillon-Lefay, Chidiac-Higashi, and cyclic neutropenia. These are conditions we kind of think of as the differential, but then we refer to a geneticist to really give us that definitive diagnosis based on genetic testing. Now, a word about early tooth loss, early tooth eruption. So my son, who is now 22, almost 23, he did not get any teeth until 17 months of age. And so normally kids are getting teeth from sometimes 6 months on through. So I was sitting there going, you've got to be kidding me. Am I going to be the dentist whose kid doesn't have any teeth? So, but then at about 17, 18 months, poor guy, he got like 9 teeth all at once. He was miserable for a couple of weeks. As a result, my wife and I were miserable for a couple of weeks. No, they tell you no sleep with kids. We got no sleep. It was just insane. And I was in residency at that time. Now, so all of us exist on a bell curve. And what this means is when we talk about teeth coming in, 80% of us are going to get teeth kind of in a normal pattern. And that's usually what we see in textbooks, et cetera. 10% of us are going to get teeth quickly. So, I've had 5-month-olds who are coming in with teeth erupting. Likewise, there's 10% of us who are going to be on the other end, and I've had 15-year-olds who still have not lost baby teeth. What's important is that we look at the sequence of eruption and loss of teeth. So for us as dentists, the sequence is more important than the actual timing. So if we are losing a tooth early, that is a red flag. Let's just make sure that what else is going on. And that is typically when we engage with pediatricians and physicians to kind of make sure there's no other systemic issues. So the recommendation for when a child should see a dentist is 6 months with an eruption of the first tooth, or at the latest by 1 year of age. The reason for that is not that we're expecting to find cavities, but it is that we can prepare parents and caregivers for how to take care of these teeth that are coming in. In Ohio, over 40% of kids under 5 have untreated dental cavities. And dental cavities can be a significant cause of pain, school issues, behavior issues. So we want to try to get ahead of this. Additionally, in situations such as this, we want to make sure that there are no systemic issues that can be identified. And very many times in talking to physicians and geneticists, early loss of teeth is one of the first signs to refer a kid for further testing. Teeth have just as much impact as many of the other things that you've seen today from the other slides. Teeth can be an early indicator of issues and can also be an early indicator of issues for the future. So in many instances, we will use that scenario of early tooth loss to get involved with our physicians and geneticists to then make sure the family has the support moving forward if there is other premature loss of teeth. Next slide, please. The types of dental abnormalities that we see in hypophosphatasia. Essentially, if you think of teeth as anchored into the bone, the issue in hypophosphatasia is that the anchoring mechanism, what is keeping the teeth in the bone, that is defective. So as a result, baby teeth can be lost, and periodontal disease, or bone disease of the mouth, of the alveolar bone, can compromise the teeth. So we look at mobility, we look at how loose those teeth are. Sometimes what we do is a test called fremitus, which is we just put our finger on where the roots of the teeth should be and have the patient bite up and down. If they're biting up and down and we're feeling like vibration or movement, that suggests to us that there's some disease process going on. It could be purely dental, but it could also be more systemically involved. So teething, abnormalities in dental eruption, late eruption of teeth. The actual symptoms of teething are the same, whether the child has hypophosphatasia or not. Typically, we're looking at low-grade fever, often pulling at their ears. There could be an overlying ear infection as well. If you live in the Ohio Valley, then you could also have sinus And we've had many kids who have overlying signs of infection, and they're getting teeth. So we try to get all those issues. And then drooling is another potential sign of teething as well. So cementum, that is the anchor that is holding the teeth in the jaws. And in hypophosphatasia, what is called acellular cementum, which is a type of that anchoring fiber, that is where the dental defect is, which is why these teeth are loose. Now, an interesting feature in hypophosphatasia and hypoplasia, which is any of these issues are affecting teeth that are growing. So if you think about the 6-year molars, which are permanent molars, those begin mineralizing at birth. So any issue in early childhood and perinatal post period can affect the mineralization and the appearance of those teeth. Sometimes they come in with kind of yellow, defective cusp tips, the very tips, and those can contribute to dental pain. Another feature of hypophosphatasia and hypoplasia is that it is very difficult to get patients numb. So giving traditional local anesthesia. So the traditional injections for local anesthesia to do fillings, to do extractions, may not always be as successful. And so in many cases, we may end up treating patients with hypophosphatasia or dental hypoplasia under general anesthesia, where they are fully asleep. The other thing that we can notice in these patients sometimes is what's known as an anterior open bite. So what this means is the patient, typically when we close, our top teeth overlap our lower teeth. Sometimes in patients with hypophosphatasia, they close and their teeth don't overlap. There's a space. Now, that can also be associated if we have children that have very aggressive thumb-sucking habits or finger-sucking habits. That's another side effect. So part of the dentist's job is to inform the parent what is a potential symptom of a condition and what is just a feature of the child being an 18-month-old, a 24-month-old, a 36-month-old. I can tell you now, and my son always hates that I bring him into all my lectures, but it helps me relate. There were plenty of times when he was younger that I would literally sit down, lay his head on my lap, put my legs over in order to brush his teeth. So I tell parents, that's not unusual. Kids don't necessarily like their teeth being brushed. They don't like you invading their personal headspace. But we still do it because we wanted to establish it as a routine for that child. So even when we have children with conditions such as hypophosphatasia, it's important to establish that routine. A lot of times, and many of my patients that I tend to focus on myself are patients who have special needs, both in childhood, adolescence, and adulthood. And I will tell you that the role of the parents is incredibly critical. And I have noticed that children that I have who have debilitating conditions come in with these amazing outlooks and amazing abilities, all as a feature of the parents empowering the kid and not letting the diagnosis define them as a person. So I have a lot of respect for parents and patients who go through this because it does require, and we're going to hear later on, a degree of resilience and a degree of kind of self-reliance to get through the system. Next slide, please. Oops, there. So we've been hearing a lot about Strensiq and the enzyme replacement therapy. So depending on when the child is diagnosed, when the replacement therapy is done, some of the defects in the teeth can already be present. So enamel hypoplasia, again, incomplete or incorrect formation of the teeth that can lead to increased dental sensitivity, that can lead to the need for interim or temporary restorations. So sometimes as these teeth come in and we can see that they're malformed, we will put sedative fillings to prevent sensitivity and further decay of the teeth into the nerves. As I mentioned, sometimes there's difficulty with local anesthesia, and then you heard both the ocular and renal calcifications mentioned as well. So when we've talked about infantile and childhood, which is really where most of the patients I tend to see are in that range. We look at preparing them for premature loss of teeth. So a key feature for these patients, if there is early loss of teeth, is as they are getting into that kind of pre-pubertal age, is making sure that there is adequate space for the permanent teeth. So in many cases, these patients might be involved with a craniofacial team, and if they are involved with the craniofacial team, an orthodontist is usually a key member there. Now, it doesn't mean that these children are going to have orthodontic treatment early necessarily. It just means that we want to know what to expect in terms of need for orthodontic treatment as they get circumpubertal or post-pubertal. Next slide, please. So this slide is talking about the effects of infantile hypophosphatasia on human dental tissue. Actually, I'm sorry. Can you go back one slide, please? So back one more, sorry. When it comes to the use of Strensiq, there are a few papers that have looked at post-enzyme replacement therapy and dental effects afterwards. The most notable effect is that the child tends to get back on a normal sequence of tooth loss and tooth eruption. Now, that is typically also related to the systemic supplementation that is occurring. We can go 2 slides ahead, please. So effects of infantile hypophosphatasia on the human dental tissue. What this slide is demonstrating is if we look on the far left, your left, that is showing that the calcium content in the cementum is greatly reduced. Again, that is what is anchoring the teeth into the bone. So that is where the defect is. Next slide, please. And this is actually showing just a histologic slide. And on the top, we have what is a normal appearance of cementum kind of junctioning with enamel. Enamel is the hard white surface of the teeth. On the bottom slide, showing hypophosphatasia, you can see that there's enamel and then there's a gap between that and a reduced amount of cementum. So this leads to reduced adhesion of the teeth in the bone and also potential increase of dental sensitivity. So sometimes in those cases, we will actually apply, essentially it's like a bonding agent, one that we use for white fillings. We will apply that on the tooth surface to actually block. There's little tubules that come out onto the tooth surface, and we block those because that is a primary etiology of dental sensitivity. Next slide, please. So in some cases with loss of teeth, there is the consideration of using prosthetic appliances. Now, a challenge in the primary dentition, so this is for kids who are typically under 8 years old. A challenge is they are growing. So if someone gets an appliance like this, very often it has to be remade or relined frequently to keep up with the patient's growth. Additionally, we do want to make sure that we are putting this in a situation where we have low aspiration risk. Removable appliances are not often favored in children because it gives the child a degree of control. So typically we like to do what are called fixed appliances, which is we put rings on the back teeth, and then there's a wire that goes behind where the front teeth would be, and the teeth, there would be fake teeth coming off of that wire. The advantage there is the child doesn't have any ability to remove it, and also cause soft tissue trauma while they're removing it and putting it in. Next slide, please. So our dental concerns, as I mentioned, premature space loss in assessment to make sure there's no complications of that later on. Very important to understand the concepts of self-esteem and aesthetics. I was going to do this, but then I realized I like my job, which is I was going to do a viral campaign in the hospital. And I was going to go around to all the pictures that they have everywhere in the hospital of all these smiling kids and parents, and I was going to black out all the teeth to like enforce the importance of dental hygiene, because we know teeth are one of the first things you see when you interact with someone. So it is very important for us as clinicians to understand that self-esteem component, particularly when we're talking about school-age children, circumpubertal children, already dealing with potential body image issues. So we do try to work collaboratively with the physician team to make sure that we are addressing that from the dental perspective. Maybe before I retire, so Howard, if you ever walk along the hallways and you see blacked out teeth on pictures, you'll know I'm probably about to retire. So yeah, that'll be my sayonara to the hospital. Next slide, please. So what's so important for us as dentists is to make sure we take a step back and we realize the impact of a condition like hypophosphatasia and any of these conditions that cause premature tooth loss on a family. It can be traumatic for the child, but it can also be very traumatic for the parents. And so our job is to come up with creative solutions and work with our physician team to make sure that we take care of the psychological maturity and growth of the child, as well as the oral, dental, and physical growth.